Good afternoon, everyone. So I am Dr. Saurabh. Title of my presentation is the full moon capsulexis, a case series presenting a novel mid-periphery capsulexis technique in intimation cataract. I have no financial interest. So if you see, intimation cataracts are notorious for completing a continuous curvilinear capsulexis of anterior lens capsule. Different surgical methods are there to address these difficulties, but all are having the same principle of an initial small controlled CCC to allow for the decompression of the intralenticular pressure, followed by a shape for enlargement of the CCC. The initial small CCC has always been started at the center with the rationale that remaining away from the periphery will reduce the chances of peripheral extension. So our aim and objective is to describe and assess a new surgical technique of achieving a safe and controlled curvilinear capsulexis in adult patients with intimation cataract by paradoxically approaching the anterior capsule at the mid-periphery. So it is a case series of 100 adult patients presenting with intimation cataract in a tertiary eye care facility in Kamrup Rural District, Assam from January 2023 to October 2024. Patient having history of serious coexisting ocular diseases were excluded from our study. All surgeries were performed by a right-handed surgeon, that is me. Preoperative acetazolamide or IV mannitol were not used in any of the cases. We have used peribulbar anesthesia in all our cases and dispersive OVD used in all our cases. So here goes one animated surgical video. So side ports are given at 9 o'clock and 3 o'clock positions. Once this is done, the trypan blue is given. The trypan blue is now washed away. So once this is done, OVD is given now. So then what we are making one small tear at the mid periphery at 6 o'clock position. So now the small axis is made. So we are calling it as a full moon because it looks like a full moon in the night sky. So once this is done, then anterior lens is now decompressed using bimanual IA. So once this is done, now we are making 2 radial tear and a large flap is made, and finally the adequate sized axis is made. So coming to the results, out of 100 patients, we are having minimum age was 25 with a maximum age of 62 years. Females were 69 and hypertensive were 17 and type 2 diabetes in 22 cases. The initial axis size achieved in 90 cases we get between 1.5 to 2 millimeter diameter, in 10 cases more than 2 millimeter. Final axis size achieved was in 4.5 to 5 millimeter diameter in 44 cases, 5 to 6 millimeter in 55 cases, and 1 case more than 6 millimeter. Fluid coming out after the initial axis, the no fluid in 61 cases, minimal fluid in 26, and excess or milky fluid in 13 cases. Initial axis size, the mean was 1.715 and median 1.75 millimeter. The final axis size, the mean median are almost same, like 5.26 and 5.25 millimeter. We did not get any complications like incomplete initial or final axis, peripheral extension of the axis margin, or Argentine and flag sign. So challenges in performing a CCC in intimation cataracts are the fragile lenticular capsule, the high intralenticular pressure, and intracapsular pressure gradient shift following opening of the anterior capsule at the center. So we postulate that creating an initial small CCC at the mid periphery in intimation cataract enables the surgeon to approach the anterior capsule at its thickest point, thereby the strongest zone, helping in easy aspiration of the cortical fibers close to the equator of the lens, thereby breaking the equatorial barrier, allows for better equalization of anterior and posterior intercapsular pressure compartments. To the best of our knowledge, the full moon capsulexis technique is the first description of a two-stage axis technique approaching the anterior capsule at the mid periphery for intimation cataracts. The technique was found to be safe and viable in creation of a CCC in our series of 100 eyes. Further studies will contribute to confirm the intersurgeon variability in safety and efficiency of the technique. These are some of the references. Thank you for your patient hearing.
So, which viscoelastic do you use?
HPMC, sir. Hydroxypropyl methyl.
So, do you think use of any hyaluronate or dispersive will help in the technique?
Yes, sir. It helps, but because it's a rural center, we use the HPMC.
Okay.
Otherwise, it helps. In the literature, it is showing that it helps.
Okay. And do you like have seen like aspiration of cortex helps sometimes?
Most of the time, because I made it a series, so I made it a serious study, so I use all cases HPMC to disperse those fluid coming out, sir.
Okay. Thank you.
Where exactly in the periphery?
Sir,
what is the site?
Yes, sir. Exactly, I'll not say exactly. It is a mid peripheral zone, sir. Yes, sir. And we have not included those cases having 6 millimeter or less than 6 millimeter pupillary dilatation. We have not included those cases, sir.